But this is New Hampshire. That is the state of New Hampshire, but similar curves in the other states. In the next slide, Massachusetts. Got it?
Yes.
In the state of Mass, if you recall, back in the spring, March and April, there was a much larger peak of cases and hospitalizations and deaths, mostly related to that 200 attendee medical conference by Biogen Pharmaceuticals at the Long Wharf Marriott, the notorious conference. Data from the CDC actually shows that that one conference resulted in about in over 300,000 cases spread throughout, in fact, the world. But this particular surge here in Massachusetts now is outpacing the surge that we saw in the spring. Lower left corner is the percent positive rate. I didn't show that in the other states, but the other states are climbing rapidly too. Massachusetts is now up to overall the middle line graph of around 6% positive rate. For the most part, throughout most of the pandemic, Maine has been below 1% positive rate. And that's where you want to be. That means you're testing enough. If you get too high, you're not quite testing adequately to keep up with the pace of the spread. I hope that makes sense. The state of Maine, I believe, Doug, correct me if I'm wrong, I think you're in the 3 to 5% now.
Correct. It's actually gotten closer to 6 with some of the recent cases, Doug, but yeah, it's been right around the 4 or 5 the last one.
Gotcha. Yeah, so Maine's following that trajectory. All right, next slide.
Okay.
This is called all positive patients. This is Covenant data going back to April, and we've tracked, color-coded each of the hospitals. Green is St. Joe's Nashua, red or orange is St. Mary's, and blue is St. Joe's and Bangor. This is the total number of new patient positives in our markets, and you can see we flattened the curve in the summer, but we're climbing rapidly starting in November. As the weather cooled, people went indoors, started swapping their viruses, and here we are. We've got that surge. And now we're seeing it in all 3 markets. What's interesting, and it might be slowing a little bit in central and northern Maine. In New Hampshire, it's not. It's still exponential. The dotted graphs are the cumulative totals of new patients each day. And the line graphs is, I'm sorry, the new patients each day, the dotted graphs, and the line graph is the cumulative numbers. Next slide.
Okay.
We also track the impact on our inpatient beds in our hospitals. In this graph, same color coding, tracks the total positive COVID patients we've had in inpatient beds, plus those that are there as PUIs, or persons under investigation. They have a syndrome that looks compatible with COVID, and we're just waiting for testing to come back. It really was not a big impact on our inpatient beds in our main hospitals, but as you can see, St. Joe's and St. Mary's are climbing. St. Mary's has plateaued off in the past week, and Dr. Smith will tell you a little bit more about that, I'm sure, coming up. Next slide.
Yes.
We track this slide to see what the impact has been in our employees. This is the solid lines are the total numbers of employees, same color coding, that are out of work due to either being quarantined because of exposure or isolated because they're infected. The orange graph showing, or the red graph showing St. Mary's, 2 big spikes in May and then again in August were related to 2 or 3 inpatient cases where there was quite a bit of spread to staff because of an unrecognized case that came in. Either they were asymptomatic or atypically symptomatic, with, for example, just intestinal symptoms and not respiratory symptoms. We learned an awful lot about exposures in those cases. But in the last month and a half, we've seen all of our cases rise. But St. Mary's has plateaued off in the number of staff being out. I think that has a lot to do with getting a system approach to managing staff that are screening out with positive symptoms, and who should really be out and who don't need to be out and quarantined, and who can go back to work to help staff our units to serve our patients better. In addition, a week or 2 ago, the CDC came out with new guidelines shortening that quarantine period from 14 to 10 days. And that's helped us out a lot too. But it's still an impact on our staffing abilities. Next slide. And briefly, this is just a slide showing the number of total open vacancies, which just compounds the challenge of our ability to staff. Before I go to the next slide deck, and as Steve, you get that opened, are there any questions about these covenant data? I apologize, I cannot see any hands being raised, but Steve, you chirp in if anyone has any questions.
Let's see. If you have a question, just feel free to unmute yourself and go right ahead and ask a question.
Doug, it's John Isaacson. Can you hear me?
Yeah, hey, John.
What's the average length of stay of a COVID patient in either whatever, nationally in Maine, in one of our hospitals? Can you just some feel as to what that is?
That's a good question. Probably Dr. Smith can give you a better idea of at St. Mary's. I'm thinking it's somewhere around 5 to 6 days, but Doug, do you have any internal information there at St. Mary's?
Yeah, it's almost exactly what it is. What John is that, we've had an incredibly variable length of stay from, folks that were barely 24 hours. We've had a couple folks that were here for weeks. Unfortunately, St. Mary's, I think my number's right, we've had 8 deaths from, coronavirus from COVID-19 here, including, as I said, one person was in the hospital for a little over a month, fortunately, before they succumbed. So to me, that's one of the amazing things. I know Doug will talk about, but just the incredible variability with how it affects people has been one of the challenges with this.
Okay, thanks.
Sure.
Mm-hmm.
Dr. Wade, I have
Any other questions?
I have the next slide up, just so you know.
All right, it says coronavirus disease 19.
Yes, correct.
All right, it does say St. Joseph Healthcare, and this is our Bangor hospital. And I, without hesitation and giving credit to Dr. Bill Wood, who just retired last week as their Chief Medical Officer of VPMA, he put these together for a similar donor presentation up there, and I've done some modification to them. So I acknowledge his work on this. So next slide, COVID-19-coronavirus. You got that, Steve?
Yes.
So a little bit about this coronavirus. When this came out, people were wondering, I'll never forget, the big fear was, can I catch coronavirus from Corona beer? And no, you can't. It's just a name. Then Corona beer were really hard to come by because people were buying them up. They thought it was cute. But anyway, coronaviruses are not new to the human experience. In fact, there are 4 coronaviruses that are the most common causes of the common cold. They've been around with us for decades. And so our bodies have gotten used to seeing coronaviruses. However, in the last 20 years, there are 2 coronaviruses that have emerged as more deadly. If you remember SARS back around 2003, that was a coronavirus. And MERS, you might not remember that, that was 2012, Middle East Respiratory Syndrome. SARS, for example, had a case fatality rate of about 10%. MERS case fatality rate of about 30%, a very, very deadly virus, but not easily communicated person to person. Far fewer cases have been experienced with these, and these did not really take off as a global pandemic. There was a scare with SARS in 2003 because it did transmit to people in various continents, but it was brought under control, mainly because it had a contagious, it had what we call an R0 rate, or the ability to reproduce, much lower than the current coronavirus. And so with mutations and with more pressure from animals and zoonotic populations, alas, more coronaviruses have spilled into the human experience. And the coronavirus that we've been dealing with now probably has as its host a certain type of weird bat species in Southeast Asia and China. But somehow it got over into the humans. This one is much more infectious than the other 2, at least SARS and MERS virus. The R0, or the reproductive rate for seasonal influenza, for example, is about 1.3. So for every 1 person that gets flu, you can infect 1.3 others. However, coronavirus, it's about 2.6. So it's literally twice as contagious as flu. As far as the case fatality rate so far of this virus, we're thinking it's going to end up being around 1 to 2%. Seasonal flu is about 0.05%. So we're talking about a virus that's twice as contagious and about 20 to 40 times as deadly as seasonal influenza. It's spread by droplet, just like every other good respiratory virus does. Your chance of getting infected is if you spend time with people cumulatively for at least 15 minutes within 6 feet of them. If you have a mask on, though, your risk of acquiring the virus from somebody at that distance dramatically drops. And this has very important implications for healthcare workers. Next slide.
Okay.
These data are from a graph. I think that's the one's particularly from the CDC. This is a heat map showing circles in various sizes corresponding to the number of cases in that particular county. You can see in spring, this is from April, big epicenters were in Boston and especially New York City. Next slide. This is what it looks like now. Epicenters all over the country, and really everybody's equally been impacted. It's been interesting to see. After the spring outbreaks, it kind of calmed down, but in the South, there was significant outbreaks in the southern states. But then as the fall approached, it really started spreading ferociously in the Midwestern and upper mountain states too. And then now we have our own surge in the Northeast. Next.
Yes.
A little bit about the experience in Maine. Ignore that circle around Penobscot because you're in Androscoggin. I already told you about the rate there. First case in the state was second week of March. There were cases have grown to close to 13,000 through current times. Most of them have been in the southern part of the state as far as total numbers, York County and Cumberland County, but Androscoggin is starting to catch up quickly, and sadly, I think Penobscot's going to go that route too. There's been over 700 deaths, 700 hospitalizations, and over 200 deaths, and that's has been growing as well. Next slide.
Yes.
This is a version of the graphs I showed you before. In the state of Maine, new cases diagnosed each day. You can see there was barely really any of an experience in the state of Maine in the spring and the summer. It really was a non-experience, but now you're seeing your first wave now. And Penobscot County is listed below, similar. Next. And I want to end with a few slides about the vaccine because this is in everyone's mind because it's in the press and because Dr. Smith and I have been living, breathing, and sleeping vaccines, right, Dr. Smith? And planning clinics and trying to understand what the manufacturers are recommending for guidance and what are the data on side effects and how do we put together a clinic. So, but it's all for good because we're protecting our staff as we speak. Next slide.
Yes.
A little bit about the two ones that are coming out now, both from Pfizer and Moderna. These are brand new technologies. It's using a form of genetic material called messenger RNA to actually take over a human's protein-making factories in your cells. This genetic material does not get incorporated into the human genome. It doesn't change who you are. It doesn't stay with you. It gets broken down very quickly, but it does get into the ribosomes where proteins are made and encodes for the production of a particular protein, which is the spike protein, these funny looking things, those red things that stick out from that CDC model you see in the picture there. The spike proteins are known to be the most immunogenic to the human immune system. So the more, when you expose the human immune system to various components of this virus, it's the spike proteins that generate the most immunity. So that's why we are using this protein. So that protein is made in your own cells, and then it's moved out to the surfaces of the cells where your immune system recognizes it as a foreign protein. And these B cells and T cell lymphocytes cluster around and develop an immune response. And it works very, very nicely, very effective. Let's see. Traditional vaccines, though, just give you the actual protein itself and inject you that way. And it could be from a virus or a bacteria, or it could be linked to a different type of benign virus, like our coronavirus, the cold virus, and brought into the human system that way. But this is quite different. Let's see, I could probably skip this. A little bit about, I don't know much about the manufacturing, but the distribution has been interesting. You've heard on the news about the challenges with the ultra-low freezers. St. Mary's has benefited dramatically from its close partnership with Bates College. a very generous institution to share their freezers with us. And as a consequence, and one of the main reasons, St. Mary's was one of 5 hospitals in the state of Maine that received the first vaccine distributions from Pfizer through the state. So well done on that. And again, one of the first hospitals to start vaccinating their staff. So we have it in our facility. I think some of your leaders were on the news. Well done. Good thing that everyone's good looking, especially Dr. Smith. But it's been a good thing for St. Mary's patients in the community of Lewiston. Efficacy. We were hoping to get 50 to 60% efficacy. Turns out these mRNA vaccines are about 95% effective at preventing infection and 100% effective about preventing very serious disease requiring hospitalization. So while 5% of people may still get the virus after the vaccine, they're much less likely to be hospitalized or to die. So far surpassed what our goals were. Safety, the side effect profile is basically, to summarize a whole lot of study of the data, very similar to the flu vaccine. Most common side effects are at the injection site. Soreness, a little bit of redness, a little bit of swelling at the site of injection. Less common are systemic side effects like low-grade fevers, fatigue, chills, muscle aches, and joint aches. And we're in the midst right now of trying to figure out, how we actually manage our staff if they're coming in with some side effects, and whether or not they are or are not able to work, and do these symptoms actually mimic COVID? Do they need to be tested? So very complex analysis and protocols for managing that, but we've got that system stood up. Next slide. Let's see, Moderna vaccine, the mRNA, the spike protein, we covered that. Next slide. I talked about the messenger RNA, and first time it's been used, codes for the protein spike. It's using our ribosomes. I think we covered all this. And there's nothing infectious about this vaccine. There's no live virus in it at all. You cannot get COVID-19 from this vaccine, and that's very, very important. Maximum efficacy is achieved about 1 week after the second shot, and there needs to be about 3 weeks between each of the 2 shots. Next.
Yes.
This diagram shows the mRNA inside what we call a lipid bilayer, a lipid membrane bilayer, where it's contained. It's injected that way. It goes into the lymph nodes where it's processed in the methodology I explained to you. Next slide.
Yep.
This is a picture of the mRNA getting incorporated into the cell, and out comes these blue spike proteins. Next slide. Then you see orange and red immune cells like B and T lymphocytes interacting with those spike proteins presented on the surface of that cell in the lymph node. And out comes an immune reaction with antibodies and T cell lymphocyte memory immunity. So that's how it works. From my perspective, looking at the data and understanding the process that they went through, and the extra stringent criteria that the FDA required with longer follow-up after phase 3 clinical trials, I feel very confident that this is a safe vaccine, very effective, very happy about that. And I will be first in line to get this vaccine as soon as I'm allowed to get it. I'm in the corporate office, so people like your emergency room nurses and doctors and your COVID units, your ICU, these are the people that are prioritized to get it, and these are the folks that did receive it today. I commend Dr. Bagley as your medical director of your ICU for getting it first, so well done, Dr. Bagley. So that's it. I could take some questions, or otherwise turn it over to Dr. Smith.
Okay, questions. If you have questions, feel free to unmute yourself and go right ahead and ask the question.
This is Pete Geiger. I have a question about schools. Seems like a lot of the infections are at nursing homes and things of that nature. What are you finding out about schools, elementary or middle schools?
Yeah, that was a topic of hot debate earlier on in the pandemic, and that's why schools shut down. We know that common winter respiratory viruses get transmitted very commonly and very frequently in schools with lots of influenza outbreaks, et cetera. As the pandemic has gone on and we've looked at more and more data, it appears that younger children do not serve as sources of transmission as much as we thought. And in schools especially, transmission of this particular coronavirus do not seem to occur as quickly as they do in other settings, like as opposed to schools, far more risky places where we know spread is quite common are restaurants, bars, church choir practices, private in-home gatherings, every time anyone's sitting around a table eating a meal, in nursing homes, far more risky than schools. So as the data unfolds, you're hearing more and more public health officials and elected officials talking about let's get our schools open, which I think it can be done as long as certain precautions are kept into place, like masking, staying apart from people as best you can, et cetera, et cetera, et cetera.
Doug, it's John I again. Something to help me more, or something to help me better understand the vaccine. Once I get vaccinated, I get it that I won't get sick, and if I do get sick, I won't get very sick, well, all of which is wonderful. What I don't quite understand yet is if I get vaccinated and I get exposed to someone who has COVID, can I sort of get the virus, not have it make me sick, but somehow transmit it to somebody else? And that I haven't seen anything yet that says that that isn't the case, which gives me pause.
That's a really, really good question. You're talking like a virologist. And nobody knew the answer to that until just within the last week. I was listening to, I think it was on NPR, or reading something that talked about one study that, I think it was the Moderna phase 3 trials that looked at the rate of asymptomatic carriage of the virus. So if you've been vaccinated, what's the chance that you can still carry this virus in your nose and spread it to someone else? And I think the rate that they said, I think it was around 80% effective at reducing asymptomatic viral carriage. Not 95%, it was somewhat less, and I might be quoting the numbers wrong. So it does have a positive impact on reducing your asymptomatic carriage of this virus, but not 95%.
Yeah, Doug, if I might, I think the other piece to it, John, is that you think about it, if you're exposed but you're not sick, it's not continuing to sort of reproduce in you, right? So you have a certain amount of virus that you would have by being around me if I was sick, but you're vaccinated. But if you yourself then get sick, that virus is reproducing itself over and over again. And so there's a lot more virus that you would share by sneezing on or talking to somebody else beside it. So it's not only is it less likely you'll actually get it and have it, but then there's a lot less of it that you could spread to somebody else.
Right, thanks. Can I ask one more question?
Yeah, that's a really good point. It's a good point. I just want to add to that. If you're not actually sneezing or coughing, you're less likely to spread this. So somebody who has not gotten the vaccine, who has gotten acutely infected and has no symptoms, they definitely can spread it to others, but their chance of they're spreading it to others is far less than if they're spewing forth infectious respiratory droplets.
Yes,
go ahead, John.
Thank you. One more totally unrelated, not unrelated, but different question is, by the time I get the opportunity to get a vaccine, someone my age, healthy, I don't live in a nursing home, don't visit hospitals and all that stuff very much. There may be an opportunity for people in our the broad category I'm in to sort of choose to some extent which one they get. If I go to CVS, I'll get vaccine A. If I go to Walgreens, it's B. If I go to my doctor, it's C, whatever it is. So is there anything sort of as a vaccine consumer that one should know and one should pay attention to other than efficacy rates?
That's a good question. And I don't think I'm going to have a good answer for you. And I at this point, I personally would not have any preference between the two. I suspect if and when the Moderna one becomes approved and we start getting shipments, and we anticipate in Bangor next week, they're just, because of the complexity of shipping and storing and freezing and thawing and diluting of the Pfizer one, the Moderna may have more readily available doses, and there might be more access to it to a wider variety of healthcare providers. That's just a supposition, and we'll have to see how that pans out. But right now, I personally would take either one, whatever's available to me.
Hey, Doug, this is Brad. What about for a non-messenger RNA vaccine like the one that AstraZeneca has been working on?
Yeah, none of the data on their safety and efficacy trials has yet been released on that one, Brad. I can't really comment on those. I can comment on the mRNA ones, and either one of them are safe and effective, and I recommend getting them. So we'll have to see what the data comes out on the other technologies that other companies are using.
And you stole my comment. Third vaccine, probably by the time it's widely available to the general population. I think to answer your question, John, too, I think the only other difference, efficacy clearly, but side effect profile, right? I mean, right now these two vaccines are very, very similar as far as what we anticipate as far as any kind of side effect after getting it. That may be different, right? There are different vaccines that are much better tolerated. That's, I think, the only other subtle difference. And as Doug said, we don't know yet with the other vaccines.
Okay, thanks.
Dr. Waite, this is Steve Costello. Dr. Smith and I were talking about this the other day, but others might like to hear a little bit about this. And that's, my daughter had COVID probably about 3 weeks ago now. Presumably she's immune at this point in time going forward. Tell me though a little bit about her ability to carry it and infect others still. And also the fact that she might test positive due to the fact she's already had it. She might actually show up as a positive test if she were to have to take the test for work, or in my case, coming into Maine, for example.
Yeah, a lot of good questions in there. I'll take the positive one. The only test that she might be positive on is the antibody test. And most people are not recommending that for any reasonable clinical application right now. It just measures if you have antibodies to the particular virus and thus have been exposed to it in the past. There is a small rate of cross-reactivity of the antibody test with other of those more benign common cold viruses. That's the one flaw of that. But really, what we're trying to do in the midst of this pandemic is detect people who actually have the virus replicating in them right now. And those tests are the PCR test and the antigen test. And those tests will not be positive if you receive the vaccine. So there shouldn't be a concern. So I wouldn't recommend I mean, let me rephrase that. An antibody test in her or anyone who's had COVID really is not that useful right now. It's not going to provide a whole lot of use. Now, whether or not after her acute infection could she still transmit this virus, very, very unlikely after day 10. Vast majority of people stop shedding viable virus at around day 9. And that's why the CDC says if you've been sick, you can come off of precautions and go back to work after day 10 as long as your fevers are all gone, your symptoms are improving for a minimum of 24 hours. So day 10 is the cutoff. Whether or not she should get the vaccine, the recommendations are, yes, people who have had COVID-19 should get the vaccine. It's recommended for these people, mainly because we do not know how long natural immunity from the infection lasts. It probably wanes over time. There's some anecdotal onesies and twosies here and there that have been reinfected with a slightly different strain, 4, 5, 6 months out after their first infection. So the rough guidance from the CDC now is within 90 days after your infection, you're probably immune to a subsequent infection. You could get the vaccine again within that time period, but since you probably are somewhat immune in those 90 days, let's prioritize the limited supply right now to the folks in the highest category, like the healthcare workers and nursing home residents, and hold off on you since you got some degree of immunity. But it looks that giving it to those who have had the infection, it boosts your immune response and it may be more longer lasting.
Okay, other questions out there? Just a big thank you to Dr. Waite. Can't tell you all how lucky we are to have an infectious disease specialist as our chief medical officer here and helping us get through this pandemic crisis. So thank you very much.
It's my pleasure. It's what we're called here to do, right?
Absolutely. Yeah, so Steve, if you don't mind, I would just walk us through a little bit of our St. Mary's experience. And Dr. Waite humbly left a little bit off of his resume. So while he was in the Southwest, not only did he help kind of discover a new virus, a new viral illness, he was actually quoted. Any of you remember the Dustin Hoffman movie Outbreak? His name is actually in it. He's quoted. I won't say the line because it's really not for mixed company, but he's in it. So if you have, like I have, you need to go back and watch it slowly so you can kind of catch the line. But it's in there, trust me. So he really left that off. But,
Nice.
But no, as Doug already said, I won't go back through all the data. I think most folks know I think not only did we plan well and execute well, but we were fortunate that Maine did not see the big surge in the spring. We were certainly prepared. Like many other places, we stood up what we call our incident command. So in other words, a multidisciplinary team to prepare for it. We had surge plans identified. We were able to identify, okay, if we, instead of our 15-bed ICU, we need more, what could we do, and identified places that we could take care of the sick folks, as well as just our overall capacity. We went through our list of staff as well as providers to say, okay, so if we now have doubled our number of patients in the ICU, how do we get more ICU nurses and those sorts of things? So really did all of that surge planning, and fortunately, we were able to put them in a binder electronically and put them on a shelf somewhere. And so really didn't have to sort of invoke those things. And I do think we had an appropriate response. People know we shut down, so to speak, pretty quickly, like most of the rest of the country. But then I think also very smartly, as we saw that the surge really wasn't happening like it did in other places, I think smartly reopened and did it cautiously. People may or may not remember, it feels like a long, long time ago, but we were really one of the first places around to start requiring mandatory masking. We were one of the first health systems to really start limiting visitation, which, while very challenging for patients and family, was, I think, something that kind of helped slow the spread here. Doug mentioned we did have a couple sort of unknown inpatients early on that helped us learn more about the disease and how it presents, but also how do we investigate if there are potential exposures and reduce the risk of those exposures. So, all of that was really, really quite wonderful. And then went through those summer months, really we didn't see much, and now, again, we're starting to see it rise again. If you look at that data, it's a little different for the county than what we're seeing in St. Mary's. Back in the spring, I don't think we ever had a day where we saw more than 8 positive tests through our lab. We have had days where we've had 12 to 15 in the past few weeks. But, and I don't know that I have an explanation, in the last 5 days, we've had 5 positive tests total. So it's really kind of interesting. 5 days does not make a trend necessarily. I'm hoping that we haven't seen the big post-Thanksgiving surge like some places have. Obviously, we're still prepared, and those surge plans I discussed, we've dusted them off and looked at them again and updated them to make sure that if, maybe when we see a significant surge now, we're not only sort of physically ready, but have the staff ready to take care of those things as well. I think one of the challenges we faced throughout is testing. People have talked about, all over testing was certainly probably the most common conversation through the first few months of the pandemic. And we were really kind of hamstrung. It really hasn't been until the past 6 weeks that we've had any real rapid testing, and really just the last week or so that we've had a significant supply of rapid testing. So without getting into all the details, it's made it very challenging for perhaps our symptomatic employees, that if we have a test that takes 3, 4, sometimes 5 days to get results, it's trickier to sort of have a strong return to work plan. And so I'm quite excited that we now have tests that we can get turnaround time in an hour or two to be able to make some of those decisions for patients as well as our own staff that are symptomatic and perhaps out on quarantine. And then Doug touched on piece to me, which is without a doubt the most exciting part of it. Steve Costello did a great job of getting some folks here when our vaccine arrived on Tuesday. And to sort of back up on that process, as we said, there's been ongoing conversations about it. I've been part of a statewide weekly call for, I can't remember how long, at least 3 months, really talking about the vaccine. And as it got closer and closer, more and more details behind that. You mentioned Bates. It's been a fantastic relationship that they were able to loan us a freezer. And with that, we were eligible to get that Pfizer vaccine. So this week, that was the only vaccine that was distributed in the state was the Pfizer version, assuming, and I haven't heard yet, whether the Moderna vaccine that's due to get its emergency use authorization today, assuming it does get approved, we are slated to get more doses of that vaccine next week. But to me, that's one of the really first rays of hope we have with this. It's been, a really challenging illness that early on people probably know there were virtually no treatments. It was basically, as we say, supportive or measures of IV fluids and some very generic medications not for this. Over time, we've developed medicine called remdesivir that people have probably heard about that really was discovered early on to be symptomatic. We've had that and used it here. Some of what's called the monoclonal antibodies that some people call it the Trump medicine, and what he got at Walter Reed there is now available to us as another treatment. But besides those treatments, the vaccine to me is the first thing that's really been able to, I think, impact the course of this, besides social distancing and masking and so forth, but from a sort of medical perspective. And so incredibly exciting. And just to walk the numbers, we were allocated 800 doses between this week and next week of the vaccine, and we were very proactive with the state, helping them understand the number of people that fit into what they're calling phase 1A, so those high-risk healthcare workers that are eligible for the vaccine at this time. We worked collaboratively with Central Maine. They had gotten their allocation, and frankly, they felt they really didn't get enough, and we felt, looking at our numbers, we this week went through our list of employees and discovered we probably have somewhere between 700 and 800 people that fit into that category, and therefore felt like we were able to relinquish, if you will, sort of 100 of our doses. So in case people hear that, just to be transparent, we did, of what we received this week, sort of surrender 100 doses to Central Maine. I think really to make sure the community as a whole receives the vaccine to the people that need it right now. So we got our doses within 48 hours. We had plans up and running. We were able to today do our first doses. So I think Steve mentioned it. Dr. Peter Bagley, one of our intensive care physicians, and one of our ICU nurses were the first two to jointly at the same time receive our first doses, which was very exciting. We had some media presence when it arrived last week, as well as today when that happened. And then 10 o'clock today, we kicked off our clinic. We didn't open it for registration until 10 a.m. yesterday, and we did 180 doses today. We were able to deliver to people. So, to me, it was remarkable on many fronts operationally, which was incredible to see a team come together and get that done. Even more so, I think the number of people that were ready and eager to do it. Covenant had done a little bit of a survey a week and a half ago or so, and basically broke down almost 1/3 of people that were saying yes, 1/3 that were saying no, and 1/3 that weren't sure. So I was worried that we wouldn't see a good response. I hope that we send out some printed information, CDC materials. I myself have been out sort of talking it up. We had the new little piece on the news, which was exciting, and I was really happy to see that the piece they chose to share from what I spoke about was around the safety of the vaccine. So I think hopefully that was part of the message that was delivered. But and just anecdotally talked to a couple people that were some of our last folks to get the vaccine today, and they literally had been on the fence. One of their coworkers had come down and got it and said, A, it didn't really hurt. B, it was a great process, and now I'm really glad I got it. And so those two of their coworkers then scheduled right away and got down and got the dose today. So I hope and expect that we'll see more of that. For tomorrow, we have the clinic basically running all day, and we have 130 people scheduled right now for tomorrow. We only have 400 doses, so we'll have to cap it at some point, but I hope we cap it tomorrow, meaning that we have exhausted sort of the supply we have for the moment. And then again, we will, as soon as we know when we'll get our shipment next week, we'll kind of put in place those other doses. And so, I'll just reiterate what Doug said. I think a lot of information, perhaps some misinformation in the lay press talking about safety and all kinds they're talking about. And there are definitely significant side effects. The second dose probably is where we see more of that. So people will get a booster in 3 to 4 weeks, and up to 70 or 80% of people have some mild side effect, be it achiness, soreness, low-grade fever, fatigue, things that probably most of us have experienced with the flu shot. And so we'll be prepared for that. But really, there's been virtually no severe reactions. And knock on wood, today we didn't have a single person that needed any kind of attention out of the 180 doses we gave. So as I said, to me, it's just incredibly exciting to sort of do it, and so this gives me renewed energy. I think many of us felt that COVID fatigue people have talked about, that we're just slogging through, and as we start to see cases rise, the concern over that. But to me, this, doesn't impact things tomorrow. We're not less likely to get it tomorrow, but I think it starts to bend the curve in a different way than we've been able to do before. So I think that's all I had sort of prepared to talk about, but welcome to take questions on any of that or anything we haven't talked about.